That does make sense. That's actually blown my mind because I've always been told that it's between this range and this range is healthy. And the only thing I've ever known, I didn't realize until the other day when Mike said that there was a British range as well. I've always looked at it as is it nanograms per deciliter, the American measurement. And
Yeah.
I remember, I think the top end they said was around about 800, where it becomes a little bit too high. And my dad, around about, I guess it's probably 4 years ago now, he managed to get stage 4 prostate cancer. And he went to the doctor and they said that, and I'd literally just read a book on somebody Montgomery, can't remember his name now, but testosterone and how when it gets lower, it's linked to increase in prostate cancer risk. Or getting prostate cancer. So I just read that, funnily enough, and then he gets prostate cancer. So then I sit down with the doctor, and he says, okay, I want to explain it to you too, with your dad here. His testosterone is around about 780. And I think they already had him on estrogen increase in tablets or testosterone decline in tablets. So his testosterone must have been a lot higher than that naturally anyway. So I would have expected it with those tablets to be around about 300-400, but his was already really high. Now, I said to the doctor, surely if his testosterone was always high, probably closer to 900 to 1,000 if you've already brought it down, and he was a healthy man when he was younger. Now that it's dropped and he's got ill, and I've read this book, should we be lowering it anymore? And he kept persisting, saying that we need to lower his testosterone even more in order to cure it. But as you get older and your testosterone drops, your immune system becomes worse. You get more illnesses, more, injuries, whatever it might be. What's the kind of thought process on that from your end? Were the doctors right, or is the medical kind of industry slightly behind once again?
Well, I think that was it Morgenthaler was the paper that you wrote.
Abraham Morgenthaler, maybe.
It could have been.
Yeah, I think he's one of the authors of the IASS. So the thing that when we talk about 700 nanograms per deciliter, it's referring to the total testosterone, but you can still be deficient in testosterone if you have high levels of SHBG. And that, I've seen that in other people, in older men who have a really good total testosterone. Like, yeah, well done. It's really good. But then if you look a bit deeper and there's a low free testosterone, usually as a result of a high SHBG level, then they actually are low. They're deficient despite how high that total is. And so because their body's not getting enough to the cells that it needs it, because it's all bound up to this protein. So that would be the one thing to consider. And the other is, that study came out and it said that there is a linkage between testosterone and prostate cancer. And the linkage is low testosterone puts a man at greater risk of a malignant type of prostate cancer. And in fact, the low levels all those years for many men may mask a more malignant form. So, you can be cruising along with very low PSA because the lower testosterone may reflect in a lower PSA, thinking everything's fine, only to eventually get symptoms. And then by that time, it may be too late because you've got it spread all around your body.
Wow.
Yeah. I mean, when you've got a active prostate cancer, depending on where you're treated, they often will, involve that sort of suppression of the androgens, basically. But I think it was 2018, and I think it was the American Endocrinology Association or the Urology Association, but it was Abraham Morgenthaler leading on that. I believe he said that now doctors the guidelines where doctors have to tell patients that there is no evidence to support that testosterone causes prostate cancer. And in fact, it may be protective, which is obviously huge when they've reviewed all the evidence, thinking that actually doctors are still, even in this country, like if you grabbed a doctor and most doctors and went, is testosterone good for you? They probably say it causes prostate cancer, that because that's drilled into them from that side of things. So when you're, depending on the doctor, I'm sorry to hear about your dad, by the way, that's
okay.
Yeah, got that. Sure. Yeah. He, the depending on the doctor that you see and the protocol and the guidelines in the area that you live and all those sorts of things, they may approach it in a certain way, and that can be suppressing androgens, and there's a whole host of things they may do, so it may vary. I know in America there are some doctors that are reducing testosterone during the time of treatment of the cancer, and then actually giving estrogen to a man whilst they are being treated, because actually estrogen provides a lot of benefits in men. Like, it does provide mood and sex drive and energy. So it's almost better than just having no testosterone or estrogen. Having estrogen is and there was some evidence showing that it actually reduced cancerous cells, which blew my mind. And they're actually, in some places, they're looking into now, sort of investigating bipolar androgen therapy, where they're giving men high doses of testosterone when they've got a prostate cancer, high doses of testosterone, followed by none, and then high doses again, and then none. I think off the top of my head, something like 400 milligrams at a time, and then stopping. And that was actually helping to fight the cancer in the prostate. So this is where it's sort of heading. But as far as I'm aware, like, the majority of places sort of in the UK and things like that, it will involve, trying to remove androgens to a certain extent. There are plenty of people in the world, if they're on TRT and they get prostate cancer, they do maybe come off TRT and they go through the whole rigmarole of what their treatment would be. And then as soon as they're back in remission, they start TRT again and are monitored and doing well, and monitored for any sort of signs of it coming back. So yeah, it may be that it's obviously just what that doctor, I get the argument though that you were saying, but obviously, particularly in the UK or anywhere where you've got a big controlling, overarching thing like the NHS, which I think the NHS is great, but it can be, I used to work within it, but it can be a big slow moving sort of ship in terms of like new evidence, because it's got to go through a lot of rigmarole, and it has its benefits, but in terms of finding out new things and implementing things, there's a cost restriction, but also it's just sort of a bit slow to catch up sometimes.
Yeah, which, like you said, it makes sense.